Any questions for the panel as a whole, or anything that any burning questions or comments for the panel? Well, I'll start it off. Victor, can you talk about some of the things that in emergency, in emergency management, some of the exciting things that you said you just came back from the conference? Can you talk a little bit about what that future might hold for your technology in emergency management?
Certainly. Well, in emergency management, intensely enough, I discovered in this meeting that virtual reality is still a novelty. They are very practical people, I have to say, in that discipline. So they stick to computers, regular computers, and they love their smartphones and things like that. So, but when they were exposed to a demonstration of how this virtual incident command system training can be conducted, they loved it. I believe, I suspect we're going to have a lot of requests for, support in the implementation of a training system like this in a number of facilities across the country. We had a very interesting experience in 2 locations recently. One was an exercise that we conducted in Cleveland. It was a multi-jurisdictional exercise. It was a large pandemic event. It was like a multi-month exercise condensed in probably around, I don't remember, 4 or 5 hours of exercise. And everybody in the room from all those jurisdictions, for example, in Cleveland, were very excited as to, they want to adopt the technology. They recommend adopting technology in their facilities. It's not easy, though, because, for example, one of the problems that we have is that computer games are not very well appreciated by emergency managers, and these things look like computer games. However, I think this is going to get very, very popular very soon.
Thank you.
My comment is for Sambin. Just thinking about what you're doing in your lab, I just wanted to find out how that, what role is playing in Alzheimer's disease prevention or Parkinson's disease prevention, and is it connected at all? I'm thinking about the imaging and all of that. How can we use it to think ahead for families and from what we know about the heredity of these diseases, and what's the role?
Very good question.
Oh, okay. I'm struggling with this kind of technology. Can handle all the other ones, but not this. That's a very good question. I think it's an active area of research for people looking at Parkinson's or people looking at Alzheimer's. For each of those conditions, you would have to tailor the virtual reality task. And also, what's great about recent technologies, as I think Victor mentioned as well, it's not just virtual reality, but because of the cheap and powerful GPUs, we also have artificial intelligence and deep learning. And so some people are a little bit afraid of that, but that can also be a huge opportunity. It is an opportunity when you're trying to find diagnostics. And that's something the NIH is doing is, for those kind of algorithms, you need these huge data sets. And so what they're trying to do is create these big open data sharing data sets so that all the data that people have collected in which they have not yet been able to find a good brain biomarker or diagnostic, they can get it all together, apply these algorithms to help find a diagnostic and have maybe an AI be the one to be able to diagnose that patient. It might change around the workforce a bit in terms of a lot of people are afraid that AI will replace a lot of jobs, and that's probably true, but it'll probably create also opportunities for them to sort of pivot into a different way of doing their job.
Great. Go ahead, Pat.
My question is for Susan. I like the work you're doing with bias. Have you done any work looking at, I can't remember the exact term for it, but when a provider, whether it's a PA, nurse practitioner, or physician, sees the same kind of patient over and over again, and then sometimes will jump to a pre-diagnosis with just, because with neuroplasticity. I'm just wondering are you doing any research like that beyond the bias?
We haven't delved into that area at all. It's a really interesting idea. And I don't actually know of anybody who is doing that.
So this question is probably more for Susan and Sunbin than for Victor, but I'm curious to know, earlier this morning we talked about the education to practice divide. And a lot of the work that you're doing, I think, can be very applicable to some of the folks that are here in the room today. And I'm wondering if you could maybe speak to very briefly about the research to practice divide. And how might we get at the work that you're doing, which we might not have known about before today, how might we potentially bridge that divide between research and application?
Yeah, so I think a lot of the first project in particular that I showed you that relates to clinical practice, I mean, I think, we're already taking it from research to training. So I think we're already starting to bridge that gap a bit. Some of the innovators who were here yesterday showed kind of the next step of what these VR technologies can look like when they're applied to training contexts. We personally are using a similar clinical simulation to the one I showed you in a context where a colleague of ours is assessing the efficacy of a pharmacogenetics training module, and then we are putting nurse practitioner students in a simulation with a patient that's a little different from what they learned in class, but with an opportunity to apply that knowledge. And so we can look at how they might apply that knowledge to a little bit of a different case, but that way we can start to look at how those lessons are sort of bridging the gap into a clinical practice-esque situation. We also sneak some research aims in there because we are researchers, but but if we can do that, then we're really starting to give educators a platform to start, looking at how some of the lessons might translate to a clinical context that isn't real, right? And so if if mistakes are made, it's not such a big deal. VR simulations can be done potentially without a preceptor. They can be practiced maybe one day at home to the extent that these technologies do become more popular. So I think there are a lot of really great potentials for VR clinical simulations to step into that role. And I think a lot of people are trying to do it. It's just there are a lot of technologies that kind of need to catch up in different ways to make it sort of the killer app. But I think we're on the road, and so I think it's really exciting.
Well, my answer might be quite field specific. What I've seen in terms of people in my field is what happens is that it's developed in a research setting. It usually goes through some sort of tech transfer department, and then a small business or even a big business might pick it up, develop it commercially into a product, and that product then gets out into hospitals, training centers. That seems the most straightforward way for that process to happen.
Thank you. Yes, go ahead, Malcolm.
Could I just follow up on that? Because I think this is a problem, this gap, this divide, the research, the education, the practice sort of issues that we're talking about. I wonder whether it wouldn't be more helpful to sort of look backwards rather than forwards. I mean, your response to how to translate research into training and education is one way of doing it, that is moving forward. But it would seem to me that there needs to be more thinking from the clinical end and looking backwards to the research and what information is necessary. So my question is really, to what degree do you folks, as part of your daily activities, apart from the discovery piece that you're largely involved with, to what degree do you have interactions with clinicians and try and think with them backwards to important research questions that you might be able to help them answer?
I can give you my answer. I think you're right, it's a huge problem, which is that researchers aren't incentivized to do that. In fact, you're kind of penalized. You don't want to mention in your paper how to make something affordable, how to make something that's going to be used by people. You usually tailor it to a very narrow audience that is looking for grants. And those grants are focused on, new concepts or that sort of practically applying what you're doing is not rewarded. That is a problem in the system. How to fix that? It's probably a pretty complicated process. Probably comes down to incentives, how to incentivize people to do that. I guess policy, you could create grants that incentivize researchers to do that. That might be the way to do it.
So I'll speak to that as well. So part of the fact that I'm embedded in the intramural program of the NIH, that actually is, probably this is the one case where that is incentivized, because I'm in the Genome Institute and I'm surrounded every day by people trying to make genomic medicine a reality, people who are very invested in personalized medicine. And so a lot of the role of the branch that I sit in is actually to think about genomic translation and translation. And so what I do is I take a lot of the upcoming problems that we see potentially to be coming down the road. So in my case, I study how to communicate about genomic factors in common disease. So complicated, and something that, if you look at how people are getting their information about genetics and common conditions right now, the answer is Dr. Phil, right? And so I really did a study on that, and that literally was where people are getting their information. So I think that I'm in the position to be able to do that, but I think, what Sunbin talked about, there are a lot of people, most researchers aren't. And so I agree that it's a big problem, but how to set the rest of the research up, like the NIH intramural program, I couldn't tell you.
Well, it just seems to me we're sitting at the National Academies, and it is one that has been a traditional role of the National Academies to look in both directions, isn't it? Not only from bench to bedside, but from bedside to bench. And education is that important, but middle sort of piece, and the training piece comes between the two. So I thank you for your candid responses, because I think, Subin, you're absolutely right that in many situations it's not rewarded, and our academic medical centers often don't reward it to the degree that it's necessary. But I think there are examples of the kind of thinking I'm advocating, and I think the National Academies has been one place that has tried to grease the skids in both directions, so to speak. And I think it's terribly important to make relevant the important work that you're doing.
Well, I'd like to thank our panelists for their great presentations.